going to be so patient, I've written these things with me. Patient traveled for 36 hours and now has lower extremity redness and erythema. Few hours later, the patient has left-sided weakness with slurred speech. What happened here? What are you guys thinking here? Any idea? Stroke, yeah, but why a stroke? What's the concept behind it? PE led to stroke, so I think you guys are missing the main point. Yeah, so it's the diagnosis here is basically paradoxical embolism. Okay, it's not a normal PE embolism. Okay, because of patent foramen ovale or ASD. Okay, atrial septal defect. So like, if you want to understand this to the core, so let's say like this is like evident that the patient has a DVT. Okay, because he has a risk factor that's traveling for 36 hours. So if we go back to heme onc, so we basically have this virtual triad where we have basically stasis, endothelial injury. Endothelial injury, what would be an example of endothelial injury? Like, how does NBME want you to know this? Endothelial injury, what would be the clinical vignette? Anyone? And hypercoagulous state. Surgery, exactly. So when you're going to be taking a patient up for surgery, you're going to be cutting off a lot of vessels and like ligating different vessels, so you can eventually cause endothelial injury. Okay, so that's why guidelines say you always have to like put a patient on anticoagulation if you expect this patient to be on the bed for the next 2 to 3 days. Okay, with heparin or rivaroxaban. Okay, hypercoagulable state. So basically, we've established the patient has had a DVT. Now, in a normal patient, when the basically DVT is like a thrombosis in the lower extremity veins, so it's going to throw off an embolus that's going to travel up to the heart. In normal anatomy, like hopefully not in you and me, this would happen. But if it were to happen in us, this embolus, it's going to make its way into the pulmonary artery. So in normal anatomy, you should always think a DVT should lead to a pulmonary embolism. Okay, but here the patient has a paradoxical embolism because there seems to be a gap in the atrial septum. Okay, so this is basically, so instead of going down, it went on the left side, went to the aorta and went into the internal carotid artery and led to basically a stroke. The presentation are completely different. If this were a normal anatomy, I would have written patient later on presents with dyspnea, tachypnea, sinus tachycardia. This patient has a stroke, and that stroke is due to paradoxical embolism coming from the DVT, and it's switching over to the opposite side. Is this clear? Is this clear? Okay, so I'm not going to just stop there. I'm going to tell you what actually is a patent foramen ovale or ASD. Okay, because these are silly questions they love asking on USMLE, and I'm not a fan of those either. Okay, so let's make it like this. So you guys need to know fundamentally how is the atrial septum formed. Okay, if before like just saying ASD, you need to know how it forms. Okay, so the first thing that would happen is basically is the septum primum is going to be coming in from the top. Okay, in first aid they've made like this huge paragraph for atrial septum formation. You can just remember this. Septum primum is coming from the top, but it doesn't reach this area. This small defect that you see, this is your ostium primum. Okay, now during the later stages, like it's not like that the atrial septum is formed within like 10 minutes, 15 minutes. It's an ongoing process while the baby is inside the mom's belly. Okay, so later on what would happen, you're going to have like small perforations in the upper part of the septum, and this, I'm going to write it with a different, make it with a different color. This ostium primum would close. Okay, normally. So septum primum first came in, we had a small gap, that was ostium primum, that later on closes. Then there's another perforation within the septum primum. This time around, this hole that you see, this is basically known as ostium secundum. Okay, it's very important to differentiate these two. Mostly students get caught up in ostium primum secundum and they mix these two, that they're the same thing, while in reality they're not the same thing. Okay, because I'm going to bring up a very important point about this, ostium secundum. Okay, now the story doesn't end there. The third thing that would happen is like later on during the stages, there's going to be a septum secundum now forming. Now this small window that you see, if I basically use it with a different color, this whole window that you see, this whole window, when it will move like this is basically known as foramen ovale. Okay, so like let's go from the start again so that you can have clarity about this topic. Septum primum was coming in and it did not reach the bottom. We had a small ostium primum. That's going to later on get filled with tissue. Later on, we're going to have like small perforations within the septum primum itself. That's ostium secundum. And then later on, the septum secundum will form, and this whole way that you see, this whole passage, that's basically your patent foramen ovale. Okay? Now, what would happen is that, why do I want to basically talk about this again and again? Because, where is it? Okay. Now, what is ASD? Can anyone tell me the most common cause for ASD? What is the most common cause? Most common type. Okay, most common type, as a matter of fact. So it's okay. I'm gonna come to down, but I want, yes, ostium secundum. Ostium secundum is the most common defect. Okay, so this one that you see, this fails to close later on. Okay, but if they ever give you a question where basically the patient has like Down syndrome features, ostium secundum, ostium primum, this small perforation that we had in the bottom initially when the septum primum was coming in. Okay, defect, always choose this option when you, in the vignette, it's trying to point you towards Down syndrome. Okay, what are the findings in Down syndrome? Because this is a multi-system integration class, I'm not going to be like traditional teachers just to like harp on one concept. So what are the findings in Down syndrome? Okay, very good. Increased nuchal translucency, very good. This is on prenatal ultrasound. Okay, then, and usually if you want to take it a step beyond, it's usually greater than 6 mm. Okay, this is more relatable to step 2, this 6 mm thing, but whatever. Then you have a single palmar crease, very good. And the palpebral fissures, Himani, you have to be specific. Okay, upward slanting palpebral fissures. Okay, because if I say small palpebral fissures or epicanthal folds, I'm pointing you towards fetal alcohol syndrome. Okay, short stature, protruding tongue, low set ears. Okay, and then if you go down to the organ systems, okay, the first one that's going to be happening in the neck is basically atlantoaxial subluxation. Okay, basically there's basically laxity between C1 and C2, and where else do we see atlantoaxial subluxation? Anyone? Very high yield point, rheumatoid arthritis. Okay, so I want to bring this to your attention. Whenever I've seen this clinically happening in the hospital as well. Okay, this is not like bogus or something. Before taking a rheumatoid arthritis patient for surgery, you have to get cervical x-ray, both lateral and anterior-posterior, okay, before intubating the patient. So basically, why do we do this? So atlantoaxial subluxation basically means there's like laxity between C1 and C2. Have you guys ever seen how do we intubate a patient? You're going to completely extend the neck like this. There's always laxity between these two guys. If you overextend it, you can compress and crush the cervical spinal cord, and the patient is going to be having a quadriplegia for the rest of their life. Okay, if you don't confirm there's atlantoaxial subluxation, you can cause the crushing of the cervical spinal cord, and that could leave the patient with lifelong quadriplegia. Extremely important. Okay, same is the thing with a Down syndrome patient. Okay, if you're going to take them for surgery, you have to confirm, like atlantoaxial subluxation is not always going to be there. It's seen in like 20% of the patients. Okay, but you have to confirm, because you then have to like go for a separate strategy, like you can go for a nasotracheal intubation then. Okay, so because you have to like basically prevent the overextension of the neck. Is this clear? Is this clear? Does anyone want me to repeat myself? Because this is a twisted concept. Okay, anyone has a question, just type up or open up your mic and just ask me the question straight out. Okay, then if you go over to the GIT, in GIT we have duodenal atresia. How does buzzwords for duodenal atresia? What is it? Anyone? Double bubble sign on abdominal X-ray, and what else? Two more signs I want to see. Two more things I want to see to confirm it's duodenal atresia on a question stem. Bilious vomiting, very good. And one more. Okay, we're going to discuss those, don't worry. One more, anyone? Gasless colon. No, I'm not talking about the cause. Gasless colon. Basically, gasless is basically, gasless basically means you have a double bubble sign. So what I'm trying to say is polyhydramnios on prenatal ultrasound. Okay, because you cannot swallow all that fetal urine. Okay. Then other than that, if we go over to the CVS, so remember I just told you that osteoprimum can be a defect in Down syndrome. If they were to ever ask you what is the most common congenital heart defect in Down syndrome, answer this: atrioventricular septal defect. This is the most common, even if they've given ASD in the options. This is basically a triad of single AV valve plus ASD plus VSD. So you concurrently have all the things.